Andy, can I hand over to you, please?
Definitely not part of the outbreak of Jane's. I will try and share my screen. Can we see that?
Yep, that's working.
Perfect. Okay. So thank you, Jane. And look, first and foremost, I'd like to congratulate Sue and ARMA on organising such a fantastic event. And also a massive thanks to Sue and all ARMA members on this call for your huge and valued contribution to MSK, especially in the very challenging context that we've experienced over the last couple of years and continue to experience. And also thanks to everybody on the call for similar reasons. So yeah, once again, apologies from me. I can only join for the first 10 minutes due to an urgent ask. It's a crazy old time in the Mo. And Jane has brilliantly stepped into the breach, Jane Hart that is, and I'm sure she'll, to be honest, do a far better job than I would. And I really look forward to hearing feedback. And I should be able to re-log in at 4. And so really keen to get tucked into the question and answers for half an hour then. So look, our vision is to promote best MSK health for all, and we want people to be active, we want to help people live life to the full, and we want to reduce unwanted variance in access, outcomes and experience. And we know that the vast majority of people present to all of us with pain. We know that pain is driven by multiple factors across a biopsychosocial spectrum, and to best support those in pain, we have to embed this biopsychosocial spectrum and its principles into a collaborative, co-produced, integrated healthcare model. And the integrated care system provides the vehicle for us to do this. It helps facilitate the preventative population health strategy required. It gives license to better integrate physical health with mental health services and also with social care and with the third sector. If delivered well, it will enable robust delivery of the biopsychosocial model. And key to this working is the relationship between the ICS and primary care networks, and how primary care integrates with both community and secondary care, and moreover, how health provision links with social care and mental health services along with the third sector. And for me, place is the integration where this will happen. And place-based partnerships are absolutely critical to help us achieve our vision. And I have got to throw in the caveat and the bias that in my day job, I'm a consultant physio at place level. So that is going to affect my view. The Best MSK Health Programme is helping to provide evidence-informed, personalised principles along the whole pathway across the multiple specialities in MSK, to inform this process and to be adapted and adopted by local leaders who have the best understanding of local population and culture and resource availability. Now, we know that leads sit in multiple different places across this pathway, across an ICS, at place level, at PCN level, and at provider level. And what we need is a collaborative approach amongst those leaders to co-produce high quality care of value to all. And so I think place in many cases will be the center point of this strategy. It will be the focal point for collaboration and for co-production to help improve access, outcomes and experience through the integrated provision of MSK services built on the principles of the biopsychosocial spectrum that drive pain, which most of our patients present. Thank you.
Thanks, Andy. You want to stop sharing your screen?
Yeah, I'm busy trying to do it. Hang on, bear with me.
A non-cooperative IT.
Yeah. Has that worked?
Yep, that's gone. Thank you. Thanks, Andy. Thank you so much. And hopefully Andy will be able to join us for the networking session at 4 o'clock. If you do have any questions, pop them in the chat. We can save them for later, or the other panel members will be able to have a look at those for you. So we're going to move on now to Jane Ferreira. Jane is head of MSK Together, which is an integrated MSK service in mid-Nottinghamshire. I believe. Correct me if I'm wrong though, Jane, please. And she's going to talk to us about a journey to value improvement and working at place level. So I'll hand straight over to you then, Jane. Thank you.
Thanks, Jane. Can I just check you can see my screen?
Yeah, we can.
Yeah, brilliant. So thanks for inviting me. Thanks to Sue and ARMA for the opportunity to talk to you all. I'm going to share a few thoughts about the journey that MSK Together have been on, looking into value improvement, specifically in the field of MSK. And this is very much about place-based partnerships and how we can better integrate our services to improve the outcomes for our population. So the NHS, as we know, is moving to a new era. We have had years and years of competition and contracts, and now we're moving towards more sustainable value-based systems, and that's the role of the ICS and moving forward in the future. And we're going to start focusing more on populations rather than the institutions that we have historically housed our services in. And when we talk about populations, populations can be focused on in segments. So, for example, people with a condition of MSK conditions, what we need to do is wrap our services around these people to make sure that we meet their needs, the health needs, and understand what the priorities are. In order to look at populations, we need to think about developing networks. So it's no longer within the four walls of a single organisation. This is cross-boundary working, cross-boundary networks, and we're shifting the focus to value, and that's the sustainable use of resources to get the best possible outcomes for our population. So in MSK Together, we're taking collective responsibility to use the finite resources wisely. And essentially that leads into a culture of stewardship, where we're thinking, how do we use these resources that we have, this known resource, to get better outcomes for the population that we serve? And this is further given strength by the new shared aim of everyone in the NHS. So this is the shared aim will be to provide better health and well-being for everyone, better quality of health services for all individuals, and also thinking about the sustainable use of NHS resources. So in MSK Together, so we've got our place of Mid Nottinghamshire, around 330,000 people, 6 PCNs within that, 2 acute trusts crossing that footprint. And MSK Together is an integrated MSK service that has been in place for the last few years, where we've delivered joined up services and pathways to provide care for our population. To further develop and move it to more of a value-based thinking, we started to develop some outcomes that matter. So historically, we've counted activity and numbers and weights and savings and finances, but now we want to really be shifting the focus onto outcomes. And to understand our outcomes that matter, we needed to ask the population that we serve. And as well, we asked all the clinicians that worked within our footprint. So with our outcomes, we then produced what we call our value framework, and this keeps us accountable. We have a set of principles by which we work, we have a shared aim, and we have the outcomes that matter embedded within that. So we know what it is that we're working towards collectively. We also did some data analysis as a baseline. We wanted to understand where our resources currently used. Are we collecting outcomes? Do we know where people are receiving care and how effective that care is? And is there any area of variation or potential inequity that could be highlighted by completing a full data analysis? And then following the data analysis, we were able to see that outcome collection was actually quite variable. So when it comes to answering some of the questions about our resource use, we weren't really clear on if we could answer the question, are we making the best use of our finite resources to improve outcomes for the population? So we've started to work on some value improvement ideas where we've started to map out the resource use, the outcomes that we get, and collectively we've agreed how we're going to do that. So all in all, that brings us to our MSK Together population stewardship. And this is where we have that culture of stewardship and a shift in the way we think and the way we speak and the way we act to try and improve the outcomes for our population. And this population stewardship forum, you can see we've got some patients in there who are involved in all of the discussions. We have complex discussions about how we get better outcomes for the resources we use in back pain, for example. We've got other organisations such as Active Knots linking into the voluntary sector, and the district councils, as well as our colleagues in primary care, the local pain services, and the acute trusts that I mentioned earlier. So a few things that have changed. So we've still got the same people in place delivering services, but we've started to shift the thinking, and we're focusing much more on outcomes and value and less on activity and conversion and spend. And trying to really bring that conversation back to make sure that we're getting that good bang for buck. The shared resource is really important because we've all essentially brought our pot of gold to the table, and we're saying, how do we use these bags of money or resources to get the best outcome that we can? We've built up trust going through a process of workshops to understanding what our shared aim is. And we've also changed our culture, which is reinforced by language and behaviour. So building on knowledge and relationships at place, we're starting to drive this continuous value improvement and understanding very much that it's a journey, and it's a journey into the longer term as well. So that's the end of that there. I'll just... Okay. Thank you very much.
Thank you, Jane. That was brilliant. Really interesting to hear about your population stewardship forum, and the fact that you've managed to create an integrated service, which I'm sure everybody on the conference today is really interested to hear about. So thank you for that. We are going to move on now to Kay Stevenson. She's our next speaker this afternoon. Kay's a consultant physiotherapist at Midlands Partnership NHS Foundation Trust. She's also Honorary Professor in Clinical Care and Leadership, and she is one of our regional AHP MSK leads for NHSE and I. So without further ado, Kay, I'll hand over to you.
Thanks so much, Jane, and thanks ARMA and Sue for the invitation. And what an amazing day it's been, really. And I'm sorry you've got me last almost. I think I've probably got the kind of slot that will provide some thinking and some thought. But I want to share in this slot some very, very personal reflections, really, of stepping into a role in our ICS, and I'm on meeting 2. So these are reflections from me as someone who's just trying to fathom our way through. So I hope you don't mind me just sharing these thoughts with you as we kind of move through the next 5 minutes and then open this up for discussion. But some fantastic work from Jane that I absolutely will be contacting you, Jane. That was just brilliant. So thank you for that. So when I was offered the opportunity to chair our musculoskeletal transformation board within our ICS, I accepted it with vigour, passion and enthusiasm, and then started to think, oh my goodness, what does this actually mean? And so when I look to NHS England around what ICS are supposed to be doing and driving, as we've all said throughout the day, it's about improving outcomes in population health. It's about tackling inequalities, enhancing that productivity, but helping the NHS in its broader social and economic development. An absolute massive agenda. So you start to think, well, how then do I start to refine this into something that I can bring people on board and deliver for our population across our integrated care system? So I looked to the King's Fund for a definition of what the integrated care system means. And there were some key words here that kind of just struck me as really, really important in the thinking of chairing this particular group at our ICS. It was about partnerships. It was about our geography. It was about somehow assessing the needs of the population and integrating that care and joining it all up, not just physical health, but mental health, and thinking about how we join health and social care together. So this really started to help me think who needs to be at this table with us as we take this journey together. And then I look for other sources of sort of inspiration, really. And building strong integrated care systems everywhere really talks about having 5 principles. And I think what you'll probably see is that we've heard of these all the way through the day. And there's principles here at ensuring engagement of everybody in our community. There is something for us to think about sharing and promoting a culture of learning through our experience and sharing our innovations. But this comes at a cost in terms of time. So people do need some protected time to be delivering this change. And so perhaps as the change agents, we are the advocates for making sure people have got time to be able to do this alongside their busy working lives as well. It may be that people within the journey with us, and I mean the broader population, have training and development to allow them to participate and show up. So I'm not just talking here about clinicians, I'm talking about everybody who's involved in our conversations. So if we need to support our patients, our partners to become familiar with the terminology, that's what we should be doing. And then transparency where our leaders are employed. So who are they and what skill set do they bring? Because certainly we've heard a lot about needing to be open, transparent, inspiring and engaging, and striving for that co-creation and co-production. And this document as well helped me in my thinking on meeting 2, that I was really starting to step into a space where the 3-letter abbreviations were abound. And so it struck me that if I was struggling with understanding what everybody was talking about, then we needed to level the playing field, and everything we need to talk about is about our lay language and make sure that the terminology is understandable by all. We've heard a little bit from Jane there about identifying that variation, but not just identifying it, being able to communicate what that means to everybody who's involved in our conversation. So when our data analyst came to present some of the data, my instruction to him was, talk to me as though you're talking to my mum. I need everybody to have access and understanding of this information that you're presenting to us. And I think at an ICS level, perhaps one of our main strengths is about overcoming barriers and trying to instill that implementation of best evidence. Because we know with our partners, with our academic institutions, we've got good quality research evidence to help us decide and improve the care that our patients get. But then again, there might be some skill sets around understanding outcome and being able to measure and understand patient experience and our resource use. And of course, monitoring, evaluating and sharing what works well. So I think there's some great pointers there that I look to in my thinking around what comes next for us. So just in summary, really, for me, going into my meeting 3 of a musculoskeletal transformation board, we've even changed the title to be transformative. I think the key element here is leadership, to make sure that we bring together the engagement, empowerment and co-production of our partners, that we identify who those partners are. So making sure the right people are with us in the conversation to help us share best practice and remove those strategic or cultural or contractual barriers that have existed before. To think about creating that culture where health don't leave the conversation, that it's an open agenda and everybody's voice is heard, welcomed and respected. And sharing that expertise from wherever that comes from, whether that comes from an academic with research knowledge, whether it comes from a patient with lived experience, whether it comes from our charitable sector with their experience, everybody needs to be as part of this conversation. And of course, communication and how we communicate and the language we use is really, really important. So I hope you don't mind me just sharing those few reflections of what I think will be important at the very start of our journey. You've heard from Jane, who's a little bit further down her journey, but this is where I'm thinking that we can make most influence and get the right people around the table to create transformative change. So thank you very much for your time, and I'm looking forward to the questions and the conversations. Thanks, Jane.
Thank you. Thank you very much, Kay. That was brilliant. Really interesting to see. And I'm sure you're all reflecting out there about how this integration is going to work. We've got people at place level working and doing some fantastic stuff, and somebody's put in the chat they're really envious of you, Jane, because you're so far ahead. But I'm sure you're still progressing and you still feel you've got further to go, because it's always a journey, isn't it, that we're on. So I'd like to start off with a question from me, if you don't mind, ladies. So we've talked about place level, we've talked about the ICS, but how can we ensure that place and ICS level do integrate? What do you see as the key things that we do? So Kay, on your last slide there, you talked about communication and all of those other things which we need to do. But on a practical level, how can we make sure that we do integrate between ICS and place level?
I think for me, Jane, it's about relationships. I think for me, it's about trying to find people across place and the systems who have influence, interest, passion, the ability to help us change and start to have those meaningful conversations. But not only that, it's about helping people understand the variation that we do have. It strikes me that I've seen quite a lot of slides that are, you know, very, very detailed. And I think if my mum was to come and join us on a conversation about, you know, with a shared experience of having back pain, how accessible would that be to her to help her show up and have conversations? So I think it's about forming those relationships, sharing our data in a way that's understandable, and trying to create that culture that is just, it's different. It's a different conversation. It's not just going to be led by health. It has to be an equal partnership.
Thank you, Kay. Anything you want to add to that, Jane?
Yeah, I think the ICS, for me, I think we just need to think about that kind of classical hierarchy top down that we maybe felt with the way commissioning went with CCGs, and how, you know, everyone went up to the top with their business cases and said, look what we can do as an organisation to save you money. And actually it needs to be inverted, and it needs to be that the ICS supports it from a bottom-up approach. So place says, you know, this is what we need, we agree on what this is, and these are the outcomes we're going to get. ICS, you need to support and maybe unlock or help us make it happen so that we can meet the needs of our population. And so I think it's going to be a bit of a shift and a challenge to change that mindset from historical CCG style, you know, the commissioning style that we've all been through for a number of years, to changing it so that, you know, and I think the ICS has got a role in allocating resources to different populations based on the needs of the local population. And I think potentially, if I think about MSK, you know, maybe the ICS has the set of outcomes that we're all accountable to deliver on, but each place has the flexibility and freedom to deliver, you know, to make the cake with their own ingredients, but we all get the same cake at the end.
Thank you, Jane. And I think you'll all agree that one of the things we've heard a lot about today that is absolutely key to the change and this bottom-up approach and all of this is the co-productive element to what we're doing. It's making sure that patients and service users and patients' representatives are included in everything we do. And that brings me to one of the questions which is in the chat. It's a question for Jane F. For your presentation, I understand the place-based discussion and new ways of working. My question is, how much do you consider the value of national patient organisations who don't have a local or regional office and are therefore perhaps less visible in local areas?
And so it's difficult to get in touch with absolutely everyone, and you always don't know what you don't know. And I think part of the evolving place-based partnerships is really getting into the detail of your local resources and your local expertise and your local intelligence, because that's where the knowledge lies. We don't need to sit there and repeat, you know, intelligence style reports when it already exists. So for me, you know, I certainly speak to one person and I get introduced to another and another, and I network all over the place. So I think it's really important, you know, regardless of the size of the groups that are out there, they've all got a valuable role to play in shaping services for the local community.
I think you're absolutely right, Jane. It's that voice, isn't it? It's that patient voice. And if it comes from one person locally or a group of people nationally, it's getting the patient voice that's really important. There's a couple of questions here, which, and this is an interesting point, which you might want to respond to, Kay, about independent providers. So, and I can sympathise with this actually. They're saying, how can private organisations best interact with the ICS for innovations that are placed to support the system? There's somebody else expressing frustration at their service being changed, and that's not necessarily the direction they think it's the best way to go. So how are ICSs working with independent providers, independent and private providers of services, many of whom we know will be on this call?
I think that's a great question, and for me, stepping into this role in sort of meeting two, I'm very conscious that they're missing from our conversation, or they're not there at the table already. But that's not to say that they're being actively excluded. As I've taken over this, there's many elements of health and social care that are missing from that table. So I don't have the voluntary sector at this point. I don't have community services at this point. I don't have the independent sector at this point. But I think the conversations that I've heard today have made me think we've had the data for some time, but what is different this time? And what is different this time, I think, is that there will be different people around the table hearing this information and co-creating solutions. So it won't be the same clinicians creating solutions. It's a broader church of people who will come together to co-produce what is suitable in that locality, depending on their population. And I think the independent sector, for me, have a place at that table because they're providing services.
Thanks, Kay. Great answer. And I think you're absolutely right. And what Ollie said earlier about 74% of private practitioners don't feel valued by the NHS, I think is right. We need a culture of change, and that's very much what we're going through. If you speak to anybody in this room, I'm sure they would say it's absolutely key. The independent sector is involved, especially now more than ever. So we make all these changes, we're moving towards integration, but what are the outcomes going to be? So a couple of questions here for you, Jane, about the outcomes that you're looking at and how you've measured them and what sort of language you've been using to do that.
Yeah, so we call them our outcomes that matter. So we sent 2,500 surveys out to the people of Mid Nottinghamshire, and we just asked them a simple question: what outcomes matter to you when it comes to MSK care? What would you like to see more of, or is there anything you would want to see less of? And we gave people the option of following us up with a semi-structured interview. So we completed 35 of those in total. And then we also asked our providers, including the independent sector, we had the local consultant orthopedic surgeon coming in, and we were saying what outcomes matter. And interestingly, so we did some kind of thematic analysis, and we ended up with 8 main outcomes, and none of them were massively surprising. It was to be able to live as good a quality of life as possible and be involved in all the things that are important to me. There were ones about being involved in decisions about my care. No one said, I want to have lots of surgery. Lots of people said, I don't want to be on medication. And everyone was saying they want the tools to be able to self-manage and be able to access services flexibly, because there's still very much, we define pathways for our patients, but then we realise that not that many patients fit into our neat pathway boxes, and actually people are much more complicated than that, and we need a network around to be able to coordinate care for individuals rather than pass them along. So the actual outcomes, we then match some measurements to them. So some of them will be patient-reported outcome measures, such as the Oxford Hip and Knee score, the EQ5D. There's the British Spinal Registry uses the Oswestry Disability Index. There's a pain score, because obviously pain came up quite high as well. And then there'll be a number of proxy measures that are embedded within different services, which are often process measures. So things like, waiting times for treatment as a proxy for kind of access to care. Things like length of stay and hospital-acquired infection and readmission rates. So there was various kind of proxy measures, and we're you know, we're not there yet. I don't want to say we're there at all, but we're looking at how we actually collect these outcomes, you know, cohesively, so that we can start to map and track where we're getting good outcomes and what we need to invest in. You know, we still need to look at our referral rates, but we're going to cut the data in a different way, cutting it by deprivation or by PCN or by ethnicity. So you can actually see if you've got an equity issue, and if you have, then what service do you need to put in that very local neighbourhood to be able to cater for that population, so that they don't end up, you know, in a really bad way in 10 years' time, and the only option they have is some kind of surgery that they probably never really wanted.
Fantastic. Thank you, Jane. And it's so interesting to hear the things you're saying, because these are not conversations we'd have been having 25 years ago, or even any time before COVID. Actually, I think it's significantly pivoted the way that we think about healthcare, which is really, really refreshing to see. Now, as we get those outcomes, we have some data, we have some evidence, and that does help us with our decision making. But there's a question here which I'll point back to you, Kay. It's a difficult one, tricky one here. You've talked about relationships a bit, but this is saying, how do patient organisations and professionals navigate the politics around place between, say, PCNs, GPs and others, or between local authorities and NHS bodies with differing views of where place and where ICS should be the appropriate level of planning? There's a lot in that question. Are you happy to have a shot at answering that one, Kay?
Yes, I think so. So I think just getting to grips with some of these tensions that might exist. I'm thinking that the data that we have that is available to us to make some of these decisions upon are, if we can make that understandable for all to contribute and participate in what that means and what that means to us with the local lens applied to it. So the data is there. Can we apply some common sense to that? Is there any explanation for that? So can we validate that with our local partners? So making that accessible. I think one of the things that is probably consistent for us is partly the population level data, but then the research evidence. So if we've got high quality research evidence that is suggesting to us, say, for example, for patients with osteoarthritis, active exercises should be promoted, then that is a conversation that we can bring back to place to say, well, if we know there's great quality evidence, high quality evidence taken from the sort of empirical research, how can we embed that? How can place embed that? And how can ICS unlock anything that's needed to be unlocked to help that happen? So I wonder whether some of the data we have from our model hospital systems and from our right care packs give us a snapshot of what we've got. The empirical research helps us look to what we're going to do about that. So where do we know we've got good quality care? How is it delivered for patients with back pain? What should we be doing based on the evidence? So I think that might help us a little bit, sort of, if that information is available and understandable to all, then I think that might reduce the politics a little bit.
Thank you. Great answer, Kay. And I think you're right, because that evidence, that data, those hard numbers, I think do really help move people in one direction or another, and hopefully all in the same direction.
I was just going to add, sorry, to that, Jane. You're absolutely right, using the empirical evidence. When we have our population stewardship forum and we're looking at back pain, which is a very tricky subject when you've got a spinal surgeon and a pain consultant and all with different competing interests. And actually, you know, we've got the outcomes, which were patchy, local outcomes. We've got empirical evidence, but we've got patients in the room who bring a level of knowledge. We've got clinicians from the front line who bring in, and it's about having that complex, cohesive discussion in a, you know, respectful way, but with understanding what the overall aim and objective is that we're trying to get towards. And actually, you know, it's less political as it goes along.
I think you're right. It is an iterative thing, isn't it? It moves forward and progresses like that. So we've just got a couple of minutes left. So I'd like to finish by asking both of you, from your very different perspectives, what are your key priorities for the next 12 months? We are where we are now. We know we're still in a pandemic. We know the ICSs are in a very much a developing state. Place level is under huge pressure because of the pandemic and winter and the elective backlog. So no easy task, but could you just give us some idea of what you think your priorities would be? If somebody said to you, what one thing do you want to deliver in the next 12 months? We get asked that a lot within the Best MSK programme. What would be your one thing that you'd want to deliver? And from a national perspective, the answer we always give is that we'd like to have the funding for a national MSK leadership network, because with that, every place, every ICS has got somebody who's leading them. So what about from an ICS level perspective, Kay?
I love that idea, Jane. I think what I'm sort of thinking is the management of those short and long term kind of aims, if you like. So we want to be able to deliver on some of those shorter term, really challenging outpatient wait times, etc. So to kind of address some of those issues, but also managing this longer term aspiration of us doing it completely differently. So having different groups around the table, having a different conversation. So there's almost this balance, isn't there, between trying to manage that short term challenge with trying to create the ambition for something that kind of has longevity to it. And I think that is definitely about getting the right people around the table. I love that idea of the funding, because I don't know about you, but I see people trying to find time in their diaries to attend meetings, to kind of, to have these discussions, and that's really challenging. So I think if we had some funding for not just clinical staff, but if we're going to create the relationship being equal in terms of the power relationships, we should also pay our patients to be with us. So let's pay our patients to be valued members. So not expect them to volunteer, but to be paid and remunerated in a respectful way that recognises their expertise. So that's one thing for me would be, let's get some funding to pay our patients to be alongside us in this co-production adventure.
You're on mute, Jane, but
I was muted. I think that means I've been told to stop talking and move on. So quickly then, before we bring Sue in, just Jane, the last couple of thoughts.
So in Mid-Knots, we're prioritising back pain because it's a huge cause of years with live with disability and burden of disease and potential area of inequity in the area. We've thought about what we want to invest in and also what we want to disinvest in. So do less off to free up some resource to do more of the good stuff. And that's the agreement that we've come to. So I would like to just have something implemented, tested, and some results to say, is it yes, doing what we think and hope, or actually are we not in the right place and we should probably pull back and think again? Because it's now about testing our ideas and measuring them, but measuring them in a very different way than we have done previously.
Fantastic. Thank you both very much, ladies. And thank you to everybody else for all of you being part of this wonderful day. Sue, I'll go back to you.
Brilliant. Well, thank you very much. And particularly thank you to Jane, who stepped into chairing this session earlier this morning. So a last minute addition, but you did a fabulous job. Thank you very much. And thank you to all of our speakers today. As I said at the beginning, I am amazed that everyone has managed to make the time, given what's going on at the moment, both to come and present, but also that so many of you have had the stamina to stay for the whole day and be as engaged as you have been. So thank you very much. And as I said at the start of the event, I am really optimistic about the future of MSK, and the level of engagement that we've had today only adds to my optimism. And today's conference was all about thinking differently, but of course thinking is not enough. We need action, and we had Craig's call to action to think about prevention and focus on that. And from Jane just now, we've had a call to focus on populations and not institutions, and how do we use the resources that we have to get better outcomes. And there's been lots of commonalities across the speakers. So we've had speakers on social prescribing, on equalities, and on co-production, but most of our speakers have mentioned at least one of those during their presentation, which is great. And then that final session talking very much about partnerships, and that's really where ARMA comes in. What we do is bring the patient voice from the patient organisations and the professional expertise from the professional bodies across the board, primary, community, secondary, and the independent sector. We bring all of that together to look at what needs to happen to deliver that vision where people have the best MSK health they possibly can, and those with MSK conditions live the best life they possibly can. So thank you everyone for joining us today. And we do now have a final networking and exhibition session that I will pop the links into the chat. So please do join us and many of the speakers in that final session.